Assalamu alaikum wa rahmatullahi wa barakatuh. Hello everyone and welcome to one of our recall sessions. For part one and today, inshallah, we're going to resume clinical management recall, okay, and some data interpretation that we missed in the last session. Hopefully, inshallah, it's going to be beneficial for most of you. And I really hope that you have started your preparation because we are 5. Yeah, we are 5 January now. So you should have started your preparation or at least revision. Okay. So let's see, we have several questions regarding gynae today, inshallah, and some surgical questions. And I hope we are going to have time for some biophysics because I know you are feeling like unsafe towards biophysics. But let me tell you, it's very easy, wallah. It's very easy when you know the mechanism around everything. It's going to be very easy questions for you. So, okay, I need your opinion here so that I can know how you are thinking and we can correct the misconceptions. We have a case here of a young lady with HMB for 8 months, okay, and trying the exam to highlight the important information in the scenario that can help you get to the right answer. I'm having HMB for 8 months, okay, only 8 months. Okay, and let me highlight. Let me highlight. Okay, so I'm having 8 months here. And she's having regular 28-day cycle. Her last menstrual period was 3 weeks ago. Okay. For the past few months, she has been feeling generally tired and noticed some weight gain. Any symptoms you should highlight because it's going to be helpful in choosing the correct management line or at least the investigation. Pelvic examination. Wow, we have pelvic examination also. Demonstrates enlarged uterus. Okay, they are asking you what are the recommended investigations you would offer to her. I need to know your opinion and then we can talk a little bit about HMB. Excellent. So the others are not going to share. Okay, by the way, I can tell you the answer quickly. I need to know what is going on inside your mind. Okay, let me ask you something, guys. Is thyroid profile a routine investigation for HMB or not? Investigating the thyroid is routine investigation in HMB or not? No, actually no. The routine investigation in HMB is only CBC. Only. This is the only routine investigation. Then, if the examination revealed any pathology, you are going to ask for ultrasound. And according, of course, to the finding in pelvic examination, you are going to make your mind between pelvic or TBS. In this case, by the way, pelvic ultrasound scan is not the best. Okay, so leave it aside now. Coagulation profile, is it routinely offered for all cases of HMB? No, it's only offered for someone who is bleeding since menarche, or she has been having a history of bleeding before puberty, or a family history of coagulopathy or hemophilia, for example. So the only routine investigation is CBC, and the GP can offer a treatment with only the CBC and the symptoms of the female. Just saying, I'm having HMB and it is interfering with my life, it is affecting the quality of my life. I cannot go out without staining my clothes, or I'm like bleeding more than 5 times per day and I don't have the ability or the effort to change the pads usually like this. Previously, by the way, we used to have a definition for excessive bleeding by how many pads are changed daily. Now, no. Now we depend on the patient's symptomatology. If it's affecting her quality of life, okay, you need a treatment. The GP can offer treatments, right? Yeah, the GP can offer Mirena. The GP can offer hormonal treatment or non-hormonal treatment. So yeah, even without referring her to you as a gynecologist, he is going only to do examination before offering a specific treatment. What would be that treatment? Not all cases are going to have pelvic examination, by the way. They are going to be offered empirical treatment just by history. But only one treatment need pelvic examination plus or minus ultrasound before offering it. Do you know what I'm talking about? Mirena, Mirena, or the IOS, or the intrauterine system, or the IOD that secretes progesterone. Okay? Mirena is the only modality that is going to need pelvic examination plus or minus ultrasound before inserting it, because you need to know if the endometrium is regular or irregular. You need to know if she's having multiple fibroids or not. Maybe this woman is going to need a surgery, right? So if she optioned for Mirena, we are going to have pelvic examination. Otherwise, she can have COCs, POPs, or the non-steroidals, tranexamic acid. Anything she needs, she can have it empirically without even examination. And of course, to rule out infection, yes. But it's going to be very obvious from the history. Here, this lady is having symptoms that could be suggestive for hypothyroidism. So I need to exclude hypothyroidism. And this is why B is the correct answer. All questions that we are having today are recall questions, by the way. Okay, so they are not like book questions or so. They are very famous recall questions, and they could come again with another format. So you need to know everything about HMB because it's very important topic. So let's see together the investigations for HMB. Usually, we can start the pharmacological treatment without investigation, history, and or examination. So if the history plus or minus examination suggests low risk of fibroids or any uterine cavity abnormality, or let's say adenomyosis, like this lady, by the way, she's having a large uterus during examination. This lady is going to have a benefit from TBS, not pelvic ultrasound. Okay, so yeah, she can have, of course, TBS, especially if it was bulky and tender. And yeah, she can have a pelvic ultrasound also. It's not wrong. So inshallah, in part two, I'm going to teach you how to choose between pelvic ultrasound and TVS theoretically in the question. Right now, I need you to remember that if a woman is going to need investigation, she is going to need it before the insertion of Mirena. So let's have a look over different lines of treatment for HMB. First line of treatment for HMB ever is what? Mirena. The Livonor Gestrel IOS. And take care that this can come as a pharmacology question, can come as a clinical management question, can come as a gynecology question. Okay, so please take care that Mirena, everything about Mirena could be a question. They can ask you about how many progesterone is there in Mirena, how much progesterone is secreted daily. Okay, and take care that the amount of progesterone secreted at first, in the first year, is much more than the second 3 years, much more than the last year. So it's like decline in the release of progesterone. Okay, so you know how much levonorgestrel is there? 52 milligrams. Excellent. 52. And how much it is releasing per day, at least in the first year? Yes, excellent. Excellent, mashallah. Okay. So Mirena should be offered as the first line of treatment. If the woman decline Mirena or it's not suitable, for example, she's having a uterine anomaly, she's having fibroids that distorting the uterine cavity, or she wants to get pregnant. And this is a recall, by the way, also. The woman needs to start a family within 1 year. Can you insert Mirena? Some candidates are going to say, yes, I can give her Mirena now. And when she starts pregnancy or conceiving, she can remove it. Let me tell you something, Dr. Amani, this is not correct. Mirena, to start working efficiently and start releasing progesterone efficiently, and you as a doctor or as a patient make your mind about the effectiveness of Mirena not less than 6 months. In the first 6 months, the patient could have irregular bleeding, she could have spotting, she could have intermenstrual bleeding. So we are not going to say that Mirena is working or not unless we wait for 6 months. So Mirena is not a line of treatment that is suitable for someone who needs to start a family even in 1 year. This woman is going to need tranexamic acid or non-steroids. Of course, she cannot take the cyclical oral progestogen or the combined COC. No way. She needs to start a family. We cannot give her any hormonal contraception. So she's between tranexamic acid and non-steroidal. Non-steroidals are the best for someone who is having also dysmenorrhea or pain during menses. Tranexamic acid is really good for someone who is not having dysmenorrhea, or non-steroidals are contraindicated. For example, someone who is having renal affection or renal disease, or some lady that she's having severe bronchial asthma. Non-steroidals are contraindicated in her case. Okay, so all those can be tricky points in the exam to lead you toward tranexamic acid or to lead you toward the non-steroidal and so on. Okay, of course, if we are dealing with fibroid more than 3 centimeters, None of those are going to work. They can be transient treatments until she's going to have a surgical treatment, but they are not definitive. They are not going to help her. Okay, and usually for part one, they are not going to bring you a case that need a surgical treatment, because to choose between them, you should know the pros and cons of each one of them. Just I need you to remember at last that the definitive treatment of severe HMB, hysterectomy. This is the definitive treatment. All other treatments are not definitive. She can have them, and then after some time, she can have the HMB again. The only definitive treatment is hysterectomy, in case this came to you as FBA or anything. Okay, we have here a scenario about ovarian cysts. So let's see if you can remember what we talked about before or not. And I still don't know why this is here. Okay, so suppose it's not correct. What do you think? A 35-year-old woman, incidental ultrasound finds a 4 centimeter simple ovarian cyst. Okay, what if I told you that the simple ovarian cyst is more than 7 centimeters? What if the cyst is more than 7? Yes, MRI or surgery. Yes, MRI or surgery. Excellent. Because it's going to be very difficult to examine the whole cyst by ultrasound because it's very big. So we can resort for MRI, or even we can go for laparoscopic cystectomy, right? Of course, laparoscopic, not open, because I'm dealing with a simple cyst. Okay, in what case you are going to order the serum CA-125 for this lady if she's having what? Excellent, complex cyst. Yes, complex cyst with solid components or bilaterality or there is ascites, signs of metastasis. Yes, capillary projections. The cyst itself is multilocular. The cyst itself is not only hemorrhagic, but there is also mixed echogenicity inside the cyst. All of those are signs for complex cyst. In this case, I'm going to order the CA-125, but she is premenopausal. Do you want to order anything else? This is very important, by the way, in making your mind about the management plan for a lady with ovarian cyst. Number one, ask yourself about the age. Number two, ask yourself about whether the cyst is simple or complex. Then the size of the cyst. Excellent, Dr. Natalia. Yes. Because she's premenopausal, I can also order the alpha fetoprotein, the HCG, and the LDH. Excellent. Because she is susceptible to have, yes, she's susceptible to have other kinds of ovarian malignancies, like germ cell tumors. Excellent. Or choriocarcinoma. Okay, we are not moving by year, we are moving by modules. We are just in the second question, don't worry. Okay, if this lady was postmenopausal with the same finding, a postmenopausal lady with 4 centimeters simple ovarian cyst, what would you do? Okay, follow up, but take care, guys. Before following up, you need to order something. Excellent, excellent. Okay, please remember my words, guys. Postmenopausal ladies are not supposed to have functional cysts. Any cyst less than 7, or let's say exactly less than 5, is usually a functional cyst. In postmenopausal ladies, this is not the case. She's not going to have a functional cyst. So why the hell she's having a cyst now? You have to order the CA125. Even if it was simple, yes, even if it was simple. Even it was discovered accidentally, yes. Unilateral, unilocular, yes. So first, I'm going to order the serum CA125. If it's normal and the cyst is asymptomatic, I'm going to follow her up in 4 to 6 months. Then I'm going to discharge her from the follow-up after 1 year. During this 1 year, the cyst has never changed in size or decreased in size. And of course, the CE level still normal. Okay, we are using the questions just to open the subject and revise as much as we can. For postmenopausal ladies, we have to calculate the RMI. Someone please tell me how you can calculate the RMI, the risk of malignancy index. We are going to multiply the menopausal state by the ultrasound features or score by the CA125 results. Excellent. Okay, if this lady, she's having a complex cyst, are you going to think twice about removing this cyst? If she is having a complex cyst and she is postmenopausal, can we just follow her up? If her RMI is less than 200? No, this is too risky. This is too risky. So any complex cyst in postmenopausal period should be removed. Are we going to do cystectomy? No, we are going to do bilateral salpingio oophorectomy. Wow, this is invasive, yes, because complex cysts in postmenopausal period, even if the RMI is less than 200, is risky. She could be borderline, or she could be malignant, by the way. RMI is not 100% specific and sensitive. The CA125 is not 100% specific and sensitive. So this is why whenever I'm having a complex cyst, I'm between two things. To do bilateral salpingio-oophorectomy, even if it was on one side, even if the cyst is unilateral, or to do laparotomy and staging. And let me tell you, the staging for ovarian cancer is very invasive. We are talking about total abdominal hysterectomy plus bilateral salpingio-oophorectomy plus omenectomy plus peritoneal cytology or clearance and lymph node clearance. This is invasive. This is a staging procedure for ovarian carcinoma. This is in case of what? In case the complex mass give RMI score more than 200. In the exam, and this is another recall, you have been treating a woman postmenopausal with a complex cyst. The RMI is more than 200. What would be the best next step? Let me give you some choices. Okay, are you going to order a CT? Are you going to refer for oncology MDT? Are you going to do the TEH plus PSO, the total abdominal hysterectomy plus PSO and omenectomy and so on? Are you going to discharge her for bariatric surgery? Are you going to counsel her about laparoscopy versus laparotomy? I can repeat if you want. Yeah, which one is first? Ordering the CT or refer her to the MDT? The CT first. Excellent. The CT first. No MDT without a CT. No MDT without a CT. We need to order the CT of abdomen and pelvis first. Exactly. So that we can have a stage. We can do staging. And then we are going to refer her for the oncology MDT. Without the CT, what the MDT are going to discuss? What they are going to discuss? You have to be prepared. Okay, so we are going to order the CT first, refer her for the oncology MDT, and the MDT are going to see the CT results with the RMI results, her physical state, everything, and they can go for fully staging procedure, or they can go for only the pelvic clearance, the TEH plus PSO plus aminectomy plus peritoneal cytology. MDT, the MDT is the group of doctors that are going to sit together from different specialties to discuss the case of your patient and come up with the best decision in her interest, multidisciplinary team. Okay, so we are going to have oncologists and gynecological oncologists. We can have the anesthesiologist. We can have a nurse who is specific in oncology. If the woman is very old, we can offer her pediatric consultation also. So many people, so many people. Okay, so that we can make our mind what would be the best plan for her. Okay, great. I love this question. Okay, a patient have normal menstrual cycles, but now she's having amenorrhea for 8 months. She's taking metoclopramide and valproate for epilepsy. She have no visual symptoms, no hirsutism. Her serum prolactin is 1000. Do you have a diagnosis? Why this woman is having amenorrhea? Because of the high prolactin. Excellent. So this is excellent. Dr. Sharihan got us a very complete, clear diagnosis. This is iatrogenic or drug-induced hyperprolactinemia. Excellent. One of the most common causes of hyperprolactinemia. Okay, who can tell me the most common pathological cause for hyperprolactinemia? No, no, not the adenoma. Excellent. Hypothyroidism. Hypothyroidism is more common than the adenoma. Hypothyroidism. Okay, so in general, the drug-induced or the iatrogenic hyperprolactinemia. But if they ask what would be the most common pathological cause for hypothyroidism, for hyperprolactinemia, this is hypothyroidism. So what do you think? Most of you said we shall stop the metoclopramide and repeat the test. And I agree. I agree. When should we review a neurosurgeon? Okay, how you would know that she's having adenoma? And what kind of adenoma? Because adenoma could be very small, and other adenomas are going to be very big. We have micro and macro adenoma. Yeah, okay, without MRI, only from here. What would you change in this scenario so that you can need a review from a neurosurgeon? Excellent, the visual symptoms. No, not the hirsutism, the visual symptoms. Visual symptoms mean that we are having macroadenoma and it is compressing over the optic chiasma. This is why you are going to need a review from a neurosurgeon. Otherwise, you are going to treat this patient just like any other case of hyperprolactinemia. And guess what? Even if you are having a macro, which is usually more than 3 centimeters, if you are having a macroadenoma and it is not compressing the optic chiasma with no visual symptoms, you can give her anti-pituitary drugs. Anyone can know which drug I'm talking about? Antiprolactin drugs. Dopamine agonist or antagonist? Yes, the capergolane or bromocraptan. Excellent. Both are dopamine agonists. Yes. Those drugs, by the way, can be used for micro or macroadenoma. Macro, yes, for macroadenoma. Specifically speaking, the caprolactone. We usually prefer the caprolactone because it's easier to be compliant for, not like the promocraptan. Promocraptan needs, let's say, a ladder dose. You are going to start with a small one and double it, then double it, then double it. So not all women are going to understand how to take the promocraptan. Caprolactone is very easy to be used. Number two, caprolactone is also very famous in stopping lactation for a lady who is having abortion. For example, she's having abortion and she wants to stop the breastfeeding. Or any woman who needs to stop breastfeeding because she cannot breastfeed. Like a lady who is having a specific infection and she cannot breastfeed ever to minimize the viral transmission to the baby. Which viral infection I'm talking about? HIV. Excellent. Yes, HIV. Excellent, guys. And this is the case for anyone who needs to stop breastfeeding because she's taking medication that is not safe in breastfeeding, or she's going to have, let's say, radiation. The question is which viral infection the woman should not breastfeed ever, even if she was in a perfect condition and her viral load is very low. HIV. This is one of the greatest lines that once we took, the amount of viral transmission to the babies is very low now. In the UK, we are talking about uh, the prevalence of HIV between neonates now is less than 0.5 because of two things: the initiation of combined treatment in pregnancy and the abolish of breastfeeding. Okay, who can tell me the answer for this one? 18 years old, primary amenorrhea, absent uterus, vagina and in a blind pouch, normal breast, can pubic hair, and she's having a history or there is now a bilateral hernia. Typical case of, excellent, guys, complete androgen insensitivity syndrome. Complete. How we know it is AIS? Dr. Amani told us because of the scant pubic hair. What else? Absent uterus could be a sign of Mullerian abnormality, like Mullerian absence. Normal breast. Normal breast is what? It could be there. It could be there for in a normal female. It could be there in someone who is having Mullerian agenesis. So this is not also the pathognomonic sign here. Yes, excellent. This is bilateral hernia. What is this hernia? Why she's having a hernia? Excellent. This is the abdominal testis or the undistended testicles. Excellent. Or more specifically, inguinal. Inguinal, it's inguinal now. because it's now apparent as inguinal hernia. So this is inguinal testicles. Sometimes, by the way, they are going to be labial also. Okay, they can present as labial testicles. So we are talking about, yeah, undistended testicles, and we are having a scanned pubic hair. This is pathognomonic for AIS, but absent uterus and vagina and in a blind pouch. So let's say I'm going to remove this. Okay, and told you that the patient is having normal secondary sexual characters with absent uterus and the vagina end in a blind pouch. What would that be? I'm so proud of you guys. Yeah, yes, the MRKH syndrome. Excellent. Okay, what if I told you that this patient is having absent or infantile uterus, normal vagina, okay, small breast, and she is short. Excellent. Turner. Yes, Turner. I shall give you a recent recall now. A recent recall is we are having a lady, okay, but she is tall with normal or slightly normal breast, other normal sexual characters, and nothing about the vagina, nothing about the hernia, and absent uterus in the ultrasound. If you have to choose one of those, exactly. She is Kleinbelter. She is Kleinbelter. For some reason, we don't, we don't, we don't need to know why. She was raised as a female. Okay, I don't care. Okay, she needs to be called a female. Okay, she's calling herself a female. She's tall. She's having gynecomastia. It's not a breast, it's gynecomastia. And of course, she's having amenorrhea and absent uterus. Definitely. You could see instead of the labias, but this is going to be very apparent in the exam. So usually they are not going to say this. You're going to see instead of the labias, you can see soft testicles. So this is going to be pathognomonic for Klinefelter. Okay, forget about Noonan syndrome. It's not in your curriculum, and it's very rare also. Noonan syndrome usually is also a female that can have a slight intellectual disability. Okay, and she's also having, let's say, not a complete sexual character and amenorrhea, of course. If I wanna ask you about, let me remove those. Okay, if I add it to this, if I add it to this scenario, okay, absence of smell or auditory problems, Kalman syndrome, and by the way, they are now so mean. They know that all candidates know about anosmia, but not all candidates know that Kalman syndrome can be having auditory problems. This is one of the features of Kalman syndrome also. Okay, so take care of this. Take care of this one. Excellent, guys. I'm so proud of you. Okay. I left you here with some notes. You want to go through it. Okay. One of the topic that appear, I think, in every exam with a different scenario. Menopausal patient came in with profuse or mild or whatever. We are having post-menopausal bleeding. What would be your first investigation? CA 125, ultrasound, or more specifically TBS, or CT scan, MRI, hysteroscopy. Yes, excellent. TBS. TBS is crucial. Any woman with postmenopausal bleeding should have a TBS. There is exceptions, okay? But for you, I'm not going to tell you the exceptions. Some cases are going to need, let's say, a jump for hysteroscopy. But this is not like the usual case. The usual case is to have the TBS first. Okay. So what would be the cutoff for the endometrial thickness to diagnose endometrial hyperplasia? 4 or more. 4 or more. Yes, 4 or more. Remember it this way. Okay, so if I'm having a picture, okay, because they tend to bring a ultrasound picture here with the uterus like this, okay, and the endometrial thickness, and the calibers are between here and here, for example, and they are telling you that the measurement between point A to point B is 1.2 millimeters. Is this woman having endometrial hyperplasia? No, without any further risk factors. Repeating, without having any other risk factors like obesity, smoking, family history of cancer, personal history of breast cancer or other cancer. What are you going to offer her? No, we are not going to do curettage anyway. Okay? We don't do this. We do Pipal biopsy or blind biopsy or hysteroscopic biopsy, and it's not curettage. But anyway, why you need a diagnostic biopsy? She's having 1.2 millimeter only endometrial thickness. So if the woman is low risk, just ask her to come back if the bleeding recurs and reassure. Just reassure her. Okay? In this case, for this woman, what would be the most common cause of this vaginal bleeding? You have no idea how much proud I am now. Yes, vaginal atrophy or atrophic vaginitis. Excellent, excellent, guys. So this is why we are going to reassure her. We have examined her. The cervix is okay. There is no pathology in the vagina. And the ultrasound is not revealing endometrial thickness, so she's fine. Okay. What if I added something to this scenario? And by the way, it is a recall also. What if I added that she was having endometrial thickness 1.2? Okay? For some reason, they did endometrial biopsy. By the way, it is a recall and I remember it very well because it was in my exam. Okay, very, very far away, but I remember it very well. She wasn't having endometrial thickness and they did endometrial biopsy, and the result of endometrial biopsy was inadequate sample. Can you make your mind whether you are going to reassure her or not? If just this is the information mentioned? No, no. I need to know her risk factors. So if there is no risk factors mentioned in the scenario, then again, I'm going to reassure her and ask her to come back if the bleeding recurs. If they mention that the woman is a smoker, she's having family history of cancer, she's having personal history of cancer, she is having continuous bleeding, or this is not her first time. She came before. She came before and she was reassured. But now the bleeding is recurring. This is another risk factor, right? Or the woman tried treatments and the treatment failed. She's having failed treatment. In this case, I'm going for excellent Dr. Aman, hysteroscopy, not hysterectomy, hysteroscopy. Not going to remove the uterus, hysteroscopy. Okay, I need hysteroscopy plus biopsy. Plus biopsy. By the way, this could be polyps. In case of inadequate sample, that means that she's not having endometrial thickness, but several polyps or multiple polyps sometimes give you the picture of endometrial thickness or endometrial hyperplasia or hypertrophy. So this could be polyps. This could be endometrial hyperplasia. I need to know what's going on there. And if she was high risk, I'm going to move in the route of endometrial carcinoma. That means that I'm going to order the hysteroscopy plus biopsy. Because this came again, I don't think, why not to bring you this? Someone who is high risk, the biopsy, the first one, this one is blind. This one is blind, not hysteroscopic. You are just going to insert the pipelle, okay, and take the sample and come out. You are not seeing where you are, from where you are taking the biopsy, whether there is endometrial pathology or not. You are just taking the sample and come out. So you could be taking sample from somewhere which is normal. It's not hypertrophied. This part, let's say, is hypertrophied or having the polyp or the, I'm not going to say hyperplasia. Okay, and they took the biopsy from here. So this is why it's inadequate. Already she's having thin endometrium. And sometimes it's going to be thick, but the biopsy is going to came out inadequate. I don't want to conflict you guys, but I'm going to finish with this. If the patient is having irregular endometrium, irregular endometrium, whether they told you she's having endometrial thickness more than 4 or not, what are you going to offer her? Are you going to offer her COTs, POPs, blind biopsy, reassure her, or hysterectomy? Sorry, hysteroscopy. Hysteroscopy. Yes, hysteroscopy plus biopsy. Excellent. Irregular endometrium means this could be cancer, this could be atypical hyperplasia, this could be polyps. I don't know. How I would know? I'm going in and see by myself. Going on in and going to use the hysteroscopy, see by myself what's going wrong with this endometrial cavity and take my biopsies as much as I want. If there is a polyp, I can do a avulsion for this polyp and it would be great. Up till now, I'm so proud of you. Okay, we have talked about this question before, but in a different format. The question that wants you to know the different classification of blood loss. Okay, and this is according to the ATLS or Advanced Trauma Life Support. So here they told you symptoms. The patient is having postpartum hemorrhage, her pulse is 140, anxious, confused, hypotensive. Forget about the capillary refill time because it's not one of the indications or one of the indices that you are going to use to calculate how much she lost. What do you think is the estimated blood loss? 45 to 55 mean that this woman is having class 4 or more and she's dying. She's dying. The woman is just anxious and confused. She's not lethargic. She's not unresponsive. And she's only 140, not more than 140. Yes, excellent. This would be 30 to 40. This is class 3. So they could bring you symptoms like this and ask you how much blood loss, estimated blood loss, okay? And they could bring you the class and ask you about the manifestation. You know that we have a talk article talking about estimation of blood loss? It's a recent talk article, okay? And I think I have sent it before to the general group. If you haven't seen it before, please tell me to send it again. In this talk article, for part 1, they could ask you what are the different methods for estimation of blood loss, which one is the most accurate, which one is carrying the hazard of infection. Okay, we can have a quick look. Can have a quick look over it. Yes, yes, sure. No problem. I'm going to send it again. Let me open it first. Here we go. You should be seeing it now. Okay, I think you can see it now. The definition of primary postpartum hemorrhage is important. The classification is important. Okay, take care, guys. This was a recall before, even before the release of the stock article. Primary PPH is when the woman loses blood more than 500 within the first 24 hours of birth. Secondary postpartum hemorrhage is when she loses blood from the second day and up to how many days? Only 7? The barbarian. 12 weeks. 12 weeks. 12 weeks means up to 3 months. 3 months. Okay, so from the second day or 24 hours after delivery and up to 12 weeks. The most common cause of secondary PPH is what? Infection. Infection. For the primary PPH, the most common cause is atony. Yes, uterine atony, a problem with the tone. Problem with the tone could be because of many things, but it is atony. Okay, the classification from 500 to 1000 milliliters, this is minor. Okay, major is more than 1000. The major PPH is further categorized into moderate and severe. For your exam, they love to ask you about severe postpartum hemorrhage. This is more than 2000. This is the record, by the way. Okay, methods of measuring blood loss. This could be exam question for you. We have mainly 4 methods: the visual, the gravimetric, photometric, colorimetric. The visual and gravimetric, both of them are good and easy, but they carry infectious hazards because you are dealing with blood. You are going to measure the blood by your eye or assess the weight. So you are going to collect the grapes, the swabs, the containers, everything that contains blood and weigh it. This is the gravimetric method. Every gram of weight is equivalent to 1 milliliter of blood loss. The photometric method is using the hemoglobin, okay, but not the bedside hemoglobin, the lab hemoglobin, not the quick hemoglobin results. Okay, by photometry is the technique that we use to get the hemoglobin result in lab. This takes time, okay? It needs a preoperative hemoglobin to compare with, but still, this is the standard method to compare the accuracy of other methods. This could be SBA. You always need the hemoglobin level before and after birth to make your mind if this woman is really losing hemoglobin or not. The calorimetric method is the most accurate so far. This is the Triton system. Triton system is, as you can see, this device. There is a screen. The screen can scan the blood clot or the drape or the swaps and has an idea about how much blood loss and what is the hemoglobin result regarding this blood loss. There is a system inside this sorry. It works by a system, automated, of course, by equations and so many things. And of course, you have to enter the patient details like the age, the preoperative hemoglobin, if the lady was having blood transfusion or not, and so on. All of these data are going to be integrated inside the computer system here, and they are going to measure the blood loss in all your drapes and give you an idea about how much blood loss and what would be the current hemoglobin. Which one, dear? The calorimetric or the photometric? Yeah, just Google Triton system. The device is going to appear to you and you are going to know how it works. But this is by far the most accurate. However, it's very expensive and it needs training. Training of the personnel, you and me. We need to be trained how to use this system, okay, correctly, or we are going to have incorrect results. Photometric method is the hemoglobin. Hemoglobin test result from the lab, not the quick bedside hemoglobin. You know that we have a quick bedside hemoglobin just like the glucose monitoring. Just like it, but for hemoglobin. This is not the photometric method. Photometric method is sending the blood sample to the lab and the lab is going to send you the results. It takes time. So you cannot use it in acute cases. It takes time. Okay, there is other information about can we use the lactate level, can we use the shock index and so on. Mainly everything in the infograph is very enough for you. And at last, we have what's called the TAG or ROTEM. TAG and ROTEM, both of them are methods of assessment of coagulation. We are measuring the fibrinogen. We are measuring the fibrinogen so that if the patient is having prolonged time, we can give her fibrinogen. Sometimes we can give her the fresh frozen plasma. There is a huge protocol depending on this, depending on the routine. Okay, so this is why we were talking about the mechanism of the tag and return, the thromboelastography and the thromboelastometry. Don't bother yourself by names. I just need you to remember that we are having stages for the management of postpartum hemorrhage. This stages, which is the obstetric bleeding strategy for waves, for the Kimball. This pathway depends mainly on the routine system, so that when the patient reach the level in which we are expecting that she has already lost more than 1,000, she's having clinical symptoms now, abnormal vital signs, we are going to use the rutam, okay, the lactate, the hemoglobin, everything that can help us know if this woman needs coagulation factors or not. Does she need fresh frozen plasma or not? Does she need fibrinogen or not? They can ask you a very simple exam question. It was a CPD question in the talk article. How many stages are there in the obstetric bleeding strategy for Wales pathway? Look at the infograph and tell me, how many stages? 4. Excellent. Yes, 4 stages. Excellent. Another very simple question that can come to your exam. When stage 3 is initiated, when the blood loss is more than 1,500. Okay, I can ask you a common recall also. A common recall would be, what would be the first surgical intervention for the management of postpartum hemorrhage? This is a recall. Battery balloon. Yes, the intrauterine balloon or battery balloon. Yes, this is the first line surgical intervention. Yes, excellent. Okay, what would be the first line of management in a patient who is having postpartum hemorrhage and atony? No, before the cento and the blood and everything. Yes, thank you so much. This is very basic, very basic. Before thinking about the medication or you are going to send her blood to the lab and you are going to make your mind if she needs blood transfusion or not. Uterine massage. Uterine massage. But, and bimanual compression. You are going to start with the uterine massage and bimanual compression, excluding that there is any retained part of the placenta. Right? Make sure that the placenta is delivered or not. Make sure if there is any cervical laceration or tear or vaginal tear. Then you can think about the oxytocin, whatever you want. Give her whatever you want. And we have a step ladder management for uterine atony. You are going to first start with oxytocin, low dose, and then give her another dose, then go for ergometrin, then go for, this is beyond part 1. I'm talking about the basic line. Uterine massage and bimanual compression. Okay, I needed to have a look over those two cases and tell me what do you think, because both of them is having the same answer. So have a look over them and tell me what do you think. Okay, you made your mind about the first one? Give me the answer for the second one. Excellent, Dr. Amani and Dr. Natalia, excellent. So you think that she could be pyrexic? She's not pyrexic. And it's only 6 hours post-laparoscopic tubal ligation. Forget about the bus. Forget about it. The white blood cells are not high, by the way. There is no way the patient is going to develop infection 6 hours post-laparoscopy. Not only it's 6 hours post-operative, it is post-laparoscopy. No way that this is infection. I need to be solid of your answer. No way that this is post-operative infection. Okay, here. What would be your lead for urinary retention or bladder urinary retention? Where's the lead? Excellent. We are having a mass, bulbable, rising up to the umbilicus and dull to percussion. Can you please tell me why it's not intra-abdominal bleeding? Someone would say that this is intra-abdominal bleeding. It's going to give you a mass rising to the umbilicus and dull to percussion. Thank you so much. Yes, the hemoglobin is 11. Do you think that a woman with hemoglobin 11 is having a bulbable mass rising to the umbilicus and it is blood? No way. Okay, here, in this scenario, what is your lead for urinary bladder retention? For urinary retention. I don't think I have written it here. Where is the question? Yes, okay. Tender mass, not relieved by analgesics. Okay. What if I told you that this woman was taking morphine? If I told you that this patient was not relieved by analgesics and she required to take morphine? What is the cause for her urinary retention? The morphine. One of the side effects of morphine or morphine is urinary retention. Yes, simply. Okay, and be solid of your answers, guys. Don't ever doubt it. Let's have a look on the causes of post-operative pyrexia or fever. Okay, no way you are going to have a wound infection just 6 hours post-operatively. No way. The only way that you could be having infection that quick, that early, is to have a pre-existing infection. The morphine can be the cause why she's having urinary retention. If they told you that she's not relieved by analgesics and she was on morphine, IV morphine or oral morphine, this is the most probably cause why she's having urinary retention. Okay, so tell me, what do you think about this one? Hysterectomy at 3 a.m. and now the first post-operative day at 22 a.m. She's having a fever 38.2. Yes, excellent. This is simply reactive temperature spike in response to stress hormones and cytokines. Physiological. Yes. Very common recall. Okay, can anyone please tell me if this woman, this option was not there? Okay. What would be the most common cause of early post-operative pyrexia? This is a recall also. No, this option is not here. What would be the most common cause? Don't go for any one of those. What would be the most common cause of post-operative pyrexia? Yes, thank you so much. Atelectasis. Pulmonary atelectasis. Whether the woman was having respiratory symptoms or not. Sometimes she is totally asymptomatic. Only a mild chest pain or a mild feeling of tachypnea or difficulty in breathing. This is pulmonary atelectasis. Pulmonary atelectasis is a response like mild fibrosis, okay? In the pulmonary uh, what do we call the covering of the lung? The pleural, yeah. It's a mild fibrosis, okay? Because of the anesthesia in the pleural. And it can go away. It's going to go away by itself. Only in severe cases we can give antibiotics and physiotherapy in severe cases, not in mild cases. Thank you, Dr. Natalia. Okay, another gynae question. This girl requests emergency contraception. She had the unprotected sexual intercourse 7 days ago, for which she took levonorgestrel. Then, last night, the condom had breached. So what do you think? Dr. Samah, apparently you haven't cleared gynecology session. Even if she was taking levonorgestrel or ulipristal acetate before, that does not mean that she is protected for the whole period or the whole cycle. She can have another levonorgestrel or UPA. And by the way, if she took Levonor before, she can take Levonor now. If she took UPA before, she can take UPA again. But don't give both of them because they don't mix. Like, for example, if she took levonorgestrel before, don't offer her UPA and vice versa. There is a problem, guys. Would you please help me? The patient cannot take UPA. She cannot take levonorgestrel. Can you tell me why? UPA, I cannot give her UPA because she took levonorgestrel before. Why cannot I give her another dose of levonorgestrel? Another tablet. No, she had last night, not 7 days before. 7 days before, she had unprotected sexual intercourse and she took the levonorgestrel. Last night, the condom breached. So I can give levonorgestrel, but this is not the reason why. The reason why I'm not going to offer her levonorgestrel or UPA. No, of course, they are emergency. This is a double dose levonorgestrel. We usually use this double dose in cases like obese patients, more than 35, PMI more than 35, or in cases where the patient is taking epileptic medication. Okay, so yeah, you can give levonorgestrel, but the reason why I'm not going to give her levonorgestrel or UPA, thank you so much. Where are you? Yeah, we are now after ovulation. After ovulation. And both of them are having weak effects after ovulation. This is why I'm not going to give her this or this. And of course, this is totally wrong. The only correct answer is copper IUD. What would be your first choice to offer any patient with emergency contraception? IUD after ovulation is not valid? Who said so? IUD after ovulation or after 19 days of the cycle, we should have pregnancy test before inserting. But IUD can be inserted anytime during the cycle, and it is the most effective emergency contraception ever. The question is, what would be the first line, the most effective contraception to be offered to any woman with emergency contraception needs? Copper IUD. Copper IUD. Definitely. Copper IUD before ovulation is going to prevent the sperm to reach the ovum. After ovulation, the copper IUD is going to disturb implantation. It can work anytime. And it is the only emergency contraception that can be given within 5 days or after 5 days of unprotected sexual intercourse. What is the time limit for UPA? Up to how long you can offer UPA from the unprotected sexual intercourse event? Only 2 days? Be generous. No. How many hours? Levonorgestrel up to 72 hours. UPA up to 120 hours. Another tricky point. There are 2 doses for UPA in our practice. This could be exam question. A case of emergency contraception, for example, she is before ovulation. Okay, so let's say she is in day 10 or 11, let's say. Okay, and she refused inserting IUD for some reason. UPA is the best choice because UPA is much better than levonorgestrel. Which dose you are going to choose? 5 or 20? Which dose of UPA is licensed for emergency contraception? So apparently you are not too good in rhyming, especially contraception. What is the dose of UPA used for emergency contraception? 30, sorry, not 20. 30. Yes, Ella 1. Ella 1. The most famous emergency contraception is 30 milligrams. 5 milligram UPA is used for the treatment of HMB in very specific cases. In very specific cases. For emergency contraception, we use the 30 milligram UPA. Also, they love to ask you about the mechanism of UPA? Anyone can remember the UPA is what? Is it estrogen receptor modulator? Is it anti-sperm? Is it synthetic progesterone receptor modulator? Is it progesterone antagonist? Okay, you know what is a sperm? You know it, or you just remember the abbreviation? No, it's not agonist. Sperm is synthetic progesterone receptor modulator. Not agonist or antagonist. It is receptor modulator. The other choices are going to be progesterone agonist, progesterone antagonist, estrogen antagonist, and other things. Okay, take care, guys. This is pharmacology. Okay, so again, please, I want to make that clear. What is the best emergency contraception? IUD, copper IUD. Okay, can you use Mirena as emergency contraception? No. Mirena is licensed for two things. It is licensed for contraception and treatment of HMB and endometrial protection. Endometrial protection. Remember my word, please. Mirena is the only IUS licensed for endometrial protection. So if a woman is taking estrogen replacement therapy, for whatever reason, she's taking estrogen replacement therapy, I can give her Mirena to protect the uterus from the effect of this estrogen. Other IUSs cannot be used for endometrial protection. This can come as exam question. Mirena is the only IUS licensed for endometrial protection. For how many years? 4 years. 4 years. FSRH guidelines say you can extend it to 5 years, but the license, 4 years. Another important update, the Mirena can be used for contraception for how many years? Previously, it was 5 years. Yes, previously it was 5 years. The latest update is that it is now licensed for contraception up to 8 years. Up to 8 years. So I'm going to send you now this update and also the PPH infographic before I forget. Okay, and you can have a look on the missed pills. How many missed pills you are going to need so that you are going to prescribe emergency contraception. How many pills of COC? You can look at the picture and tell me. How many COC you are definitely going to give the woman emergency contraception? If she forgot, how many? No, not really. My Myrina is not going to affect the FSH up to the level that it can mimic menopause. No, because the release of progesterone is gradual. It's not fixed. It's going to cause endometrial atrophy, okay? Just like as if you have done ablation. This is like chemical ablation of the endometrium. Okay, so my question was how many pills the woman is going to forget so that you are going to give her emergency contraception more than 7. Yes, thank you, Dr. Sharihan. More than 7 in any time, in any week. More than 7, consider emergency contraception. But if the woman forgets 2 to 7, 2 to 7, in week 2 or week 3, emergency contraception is not required. What is week 2 and week 3? Our cycle, let me use another color, is composed of 4 weeks. Okay? So we start with the menses here, and then we are going to have a week after menses, second week, third week, have another menses. Okay, let me finish this. I'm going to tell you how. So you are having menses, okay? Week number 1, 2, 3. Those are the 21 days of the pills. The 21 days of taking pills. And then we are having a free week. 1, 2, 3, and then we are going to have a free week. This free week is called HFI, hormone free interval. This week is the most dangerous, and the week after it. Okay? So if the unprotected sexual intercourse happens in the free interval here, or the week after the hormone interval, the hormone-free interval, the woman is going to need emergency contraception, especially if she was not really complying to her pills in this week. Okay? Exam question could be, if a woman forgot to take 2 pills anytime, in any week, what would be your advice? My advice would be, take the most recent missed pill as soon as possible. Continue the remaining pills at the usual timing. Use condoms for the next 7 days. Or avoid sex in the next 7 days. Why? Because her protection now is jeopardized. There is a hazard that she could become pregnant. Okay? So if she miss 2 to 7 pill here or here or here, we're going to advise her to do so and so, but we're not going to give her emergency contraception. But if the unprotected sexual intercourse happens in the week after the hormone-free interval week, this woman needs emergency contraception. Okay, I'm talking about what? I'm talking about the COC. Take care, two or more, not one pill. One pill anytime, no need for emergency contraception. No need. Okay, now your question. Oh, yeah, good question. Good question. So Dr. Natalia is saying if a woman is already 50 years and she was having Mirena inside, now there is no vaginal bleeding, she is amenorrheic. How can I know that this woman is menopausal or not? Can I run the FSH? Yes, yes, you can. Yes, you can. If the FSH is high, this woman is really menopausal and she can remove the Mirena. This is the only situation in which you are going to use the FSH for the indication of menopause in someone more than 50 years. In women who are more than 50 years, we don't depend on the FSH. We only depend on two things: amenorrhea for 1 year and menopausal symptoms. This is the definition of menopausal state. But if this woman was taking POPs or Mirena or implant or Dempa, all those can lead to amenorrhea. How I'm going to know that this woman is really menopausal or not? You can run the FSH. This is your question, right? Okay. So let's see the other question as well. Yeah, if you forget the POPs, this is also exam question here, guys. The time limit. The time limit. How long you are going to consider that a woman who is taking POPs is late? POPs tend to have a specific timing. If she crossed this limit, she's going to consider additional protection. So if the woman was taking traditional POP, anything other than disogestrel, anything other than disogestrel. Disogestrel, by the way, is the famous POP of Pfizer. Anyone can remember its name? That would be great. Anyway, she can be safe up to 36 hours since the last pill, or 12 hours late from her usual timing. So suppose she should take her pill by 4 a.m. She forgot it, okay, up to 4 p.m. This woman is in danger now. This woman is in danger. She forgot it more than 12 hours. So when she remembered, it was like 5 or 6. So this is more than 12 hours from her usual timing, or more than 36 hours since the last pill. So let's suppose, okay, she took it at 5 p.m. Okay, and now she's going to calculate according to this. Is this right or wrong? Shall she calculate according to the usual timing or the new timing? The usual timing, excellent. The usual timing, not the new timing. So if it's more than 36 hours than the last pill taken, this woman needs emergency contraception if unprotected sexual intercourse happens. This is exam scenario. A woman who is taking POPs, whatever type of POP, and now she has been late, okay, more than, let's say, 48 hours. This is too long. This is too long. And unprotected sexual intercourse occurs. What should you do? Give her emergency contraception. Okay, let's say that the woman asked you, okay, by telephone. She called you and she said, I'm taking a POP and I am 5 hours late, 6 hours late. You are going to tell her, take the next pill at the usual timing and take the subsequent pill at the usual timing also. This could lead to 2 pills in one day. Yeah, okay, it's okay. And you are going to use condoms or avoid sex for 48 hours. Not like the COC. In case of COC, she's going to avoid sex or take additional contraception for 7 days. 7 days. Here, for 48 hours after restarting the pills. Okay, you forgot it, it's okay, take it now. She's going to say, but the next one would be in 1 or 2 hours. It's okay, you can do this. So I'm going to take one now. And then the next one, the usual timing is within 4 hours. Is it okay? Yes. It's within 1 hour. Is it okay? Yes. That's it? No. You have to abstain sex or avoid sex or use condoms for at least 48 hours. So far, so good. So as you can see, these orchestral POPs are stronger than the traditional POPs because the time limit that a woman can forget, okay, is much more than the other. Anyone know the famous disogestrel? The famous one, Tirazet. Okay, this is Pfizer. Okay, so we have now urogynecology question, but I think it's now 2 hours. So what do you think, guys? Shall we have another meeting like tomorrow? I'm having a meeting. After tomorrow. We can have a meeting on Thursday. I prefer small sessions more than long sessions. This is my humble opinion, of course. If you have another opinion, I'm all yours. So what do you think? Can we meet on Thursday? Shall we vote on the timing between morning or afternoon? I'm all good. Thursday, I'm free. Okay, I'm going to send the vote to the groups, and I need your cooperation. Yeah, sure, why not? We can do this question, of course. Okay, we are having a woman here. She's having urgency, urgent continence, frequency, nocturnal. Fortunately, they give you the diagnosis, overactive bladder. This is a typical overactive bladder. She does not have any signs of prolapse. Her PMI is okay. What would be the first line treatment for this patient? A woman with overactive bladder. What would be the first line of treatment? No, we use something before medication. Yes, excellent. In case of OAP, we are going to offer her bladder training. In case of prolapse or stress incontinence, pelvic floor exercise would be the first line of treatment. But she's having a pure overactive bladder, this would be bladder retraining. Okay, if the woman is having prolapse or stress incontinence, which means that this is because of weakness of the pelvic floor, we can offer her pelvic floor muscles. Both of them, both of the two ladies here, the one with prolapse or stress urinary incontinence, or this woman with overactive bladder, or someone with mixed incontinence, both of them can be offered also physiotherapy. When this line fail, we are going to shift for medication. In case of stress urinary incontinence, medication usually does not work, so we are going to think about surgical maneuvers. And before surgical maneuvers, we have some maneuvers. This is going to be long. This is why I told you, leave it for next time. Okay, so that we can talk about types of incontinence, the lines of management, and how to interpret the urodynamics, because this also appear in your exam. You know this? A urograph can appear in your exam. Something like this. Six weeks. Pelvic floor muscle training is different. Okay, so I'm going to send you a vote to the group. Inshallah, I need your cooperation, please. And we are going to have the urogynecology next time. Thank you so much. Thank you so much, guys, for attending. I didn't feel the time at all. Okay, but I'm so sorry, but I have another meeting. So let's meet on Thursday, inshallah. You choose the time. Okay, take care, everyone. Thank you, dear. Thank you so much. Okay, and see you next Thursday, inshallah.